relapse of multiple myeloma is still something that we really have to work very hard on. The fact of the matter is that our treatments don't get rid of this disease. So even though a patient's gone into a very, very good response, we know there is still some myeloma lurking in the patient, and eventually that disease will regrow and cause what we call a relapse. And this is why we can't yet talk about a cure in multiple myeloma, because our treatments don't eradicate the disease completely. So a relapse is an inevitable consequence of the fact we can't eradicate the disease yet. And sadly, I think it's going to be part of our approach to myeloma patients for the near future, because we still haven't quite got rid of every last tumour cell. A relapse is confirmed in the patient often by this protein that the myeloma produces. The level in the blood starts to rise. I think a lot of patients with multiple myeloma, when they are in remission, worry about how they might present. So a lot of patients have taken a time to come to a doctor, as we've discussed, when they first present. And I think they worry that they're going to get ill at home before we notice they've relapsed. And I'd like to reassure them that in most cases, the doctor will pick up the first signs of relapse often before they get symptoms. But the signs of relapse are often that this protein the tumour produces starts to rise again, and that's a sign that the myeloma is waking up, if you like. It's starting to emerge from its treatment. The diagnosis of relapse is very similar to the diagnosis at the beginning. We want to measure the protein level in the blood and in the urine. We will want to do another bone marrow, because that will tell us if the disease is starting to grow. And as again we said at the beginning, we want to check skeletal health. How is the bone being affected? How are the kidneys being affected? But I must emphasize that if a patient's in a myeloma clinic, the most common form of relapse is often the doctor noticing the protein rising while the patient is still well. And often the patient can slowly relapse, and it's not always the case that the doctor wants to rush back into treatment if the relapse is a very slow process. A relapse is a difficult time for a patient. If they're in remission and have enjoyed being in remission, the fact their disease is coming back is always difficult news for a patient to hear. It means that they have to go back onto treatment. It means they start to re-worry about how the disease is going to affect them. And I think it brings them up that they've enjoyed a good remission, but actually things are changing. So I find that consultation around relapse is always a difficult time. Often with patients, though, they are well informed, so they know their protein level, so they often can spot a relapse with the doctor. And the important thing is that the doctor communicates the concern about the rising protein level, so they can face the next treatment together. And again, it's important to communicate the results clearly, and for the patient to know exactly what you're doing about their results. I think a relapse is a difficult time, and again, it's an important time to support the patient as they come to terms with it. Traditionally in myeloma, remission is the best time, so we always want the longest possible remission for patients. The first remission in many patients is the longest, but that's not always the case, and with newer drugs and with good treatments, often they can achieve just as good a remission with second-line therapy, with treatment of third-line therapy. And again, it's important for us as myeloma doctors that at relapse we start treatment before the myeloma causes any further problems, and that's why people will often initiate treatment at relapse when the patients haven't developed much in the way of symptoms. There is no limit to how many relapses patients can have, and again, it's an individual thing, but again, it's the doctor talking to the patient about what treatments you might use in relapse. But no, there is no limit to how many relapses can be treated. It's about finding the right combination to get the disease back under control, and it will vary from patient to patient. What refractory means is that myeloma has grown resistant to the treatments we're using. So we're giving the patients the treatment, but the myeloma continues to grow. An analogy would be a throat infection where the doctor's treated the patient with antibiotics and the patient hasn't got better and often needs a second course of antibiotics. So if we have refractory disease, it might be that the myeloma is growing through treatment and we need to find a different treatment to get the disease back under control. It's very important that we keep working on this because ultimately most patients' myeloma will eventually become refractory to treatment. That may take many years to happen, but we want to develop drugs which will prevent that refractory nature of the disease. Ultimately, our aim must be to eradicate the cancer cell so it hasn't got the chance to develop resistance mechanisms. At relapse, patients should think again about their disease, what treatments they want to have, what treatment the doctor wants to give them, what side effects those treatments will have, how will it impact on their life, do they have to have intravenous drugs, do they have to have tablets, what side effects are the drugs going to give them, and again, deeper questions, how is the treatment going to work, for how long is it going to work? Now those are questions the doctor won't be able to answer, but it's important to have that discussion with the doctor about where you're going with the treatment, what are you trying to achieve. Relapse is a difficult time for patients. So a lot of support is often given to patients when they're first diagnosed with a malignant disease. And I think relapse is just as difficult a time as when the patients are first diagnosed. So they need all sorts of support. They need input from clinical nurse specialists, from the Macmillan team. They need information about where the treatment's going. They need social work input. They might need to get a closer relationship with their GP and the home team because some patients want to be managed closer to home than they do at the hospital. They want to know about their prognosis. How are they doing? What does the future hold for them? Can they go on holidays? What about the holiday they booked before they relapsed? How are they going to get help with that? So relapse, I think, has to be recognised as a very difficult time. And all the support we give patients when they're newly diagnosed should be available for the patients when they relapse.